Through innovation, academic excellence, and family-centered clinical care, Children's Mercy Kansas City is transforming outcomes for children around the world. Welcome to the audio interview series, Transformational Pediatrics, with host Dr. Michael Smith.
Welcome to Transformational Pediatrics. I'm Dr. Michael Smith, and our topic is Home Ventilator Program, treating infants and children in the comfort of home. My guest is Dr. Winston Manimtim. He is the Associate Professor of Pediatrics at the University of Missouri, Kansas City School of Medicine. Dr. Manimtim, welcome to the show.
Thank you. Good afternoon.
So let's start with how often is ventilation actually needed in the NICU setting?
Okay, it really depends on the type of the neonatal intensive care unit. The typical neonatal intensive care unit has majority of infants being admitted for extreme prematurity, and therefore those infants are being ventilated for extreme prematurity of their lungs. In a regional referral NICU, just like ours here at Children's Mercy in Kansas City, majority of our infants are actually the later gestation, meaning closer to term, with obviously a much different set of respiratory pathology, some cardiac malformation, and other anatomic abnormalities, some gastrointestinal, and those kind of things. So being a referral center, we see a lot more complicated infants who at that point still needed to be on the ventilator.
Yeah, and you're seeing ultimately what ends up being some long-term ventilation issues, right? And that's the whole point of your program, is trying to establish a more home setting where the child can get the appropriate care in a long-term ventilation setting.
That is exactly correct.
So what's the primary, in most cases, what's the primary cause of a newborn requiring ventilator support?
Well, in our program, we see that majority of our infants are still those who were born very prematurely, who eventually required prolonged mechanical ventilation and could not be weaned off the ventilator, and that's why they go on to continue to require ventilation up to the point that we can get them home. Some of our infants also come with malformations, either of the airway or the facial malformation, those kind of issues that require their airway to be bypassed. And so those are another group of patients. We do have a big number also of babies who were born with congenital heart defects who may be in different stages of their heart defect repairs that may continue to require ventilatory support. And so those are another group of patients that we follow. And then there's a few who have central nervous issues, who, for whatever reason, are not able to breathe independently on their own, and so eventually will require home ventilation as well.
So what is there some guidelines? I'm sure there are some established guidelines that determines, which newborn can go home on ventilation, because that's ultimately, I know what your program is really gearing to do. But are there some guidelines that you follow that helps you to decide whether a newborn needs to stay in the hospital on ventilation or go home on ventilation?
Right, and we do have a specific guidelines and sort of like practice guidelines that help us decide exactly what you said, if the baby is a candidate for prolonged mechanical ventilation at home. There are other programs in the country that are doing the same thing, and we probably are almost in the same sort of like situation when we decide at some point that okay, this is time for this baby to be prepared to go home on a ventilator instead of keeping the baby in the hospital indefinitely.
And so when you, how long, so if you, in the children that are allowed to go home on ventilation, are these children that are close to being weaned off ventilation? What's the length of time usually a child is on ventilator support that are allowed to go home?
Well, it depends primarily on the primary indication for why they needed a mechanical ventilation in the first place. For our large number of patients who are former extremely premature infants who became ventilator dependent, we see them and we're able to send them home, and within the next 6 to 12 months after they go home, we are able to successfully wean them off the ventilator. Although at that point in time, they're not ready to come off with their tracheostomy, which is the breathing tube that is connected to the ventilator. But on the average, by the time they're about between 3 and 4 years of age, they're completely off the ventilator and off the tracheostomy. Other children whose indication is different, like for example, if the indication for continuing mechanical ventilation is neurologic, those are the kind of patients that may stay needing the ventilatory support for a much longer period of time.
So I have some information here. It says Children's Mercy Program is one of the largest in the U.S. with more than 25 new patients treated each year. I assume that's in the home setting ventilation program.
Correct.
Have you treated enough children at home on ventilation to be able to talk about outcomes at this point? Positive outcomes, negative outcomes? Is there any data on that at this point?
We do have an ongoing data collection for all of our patients that we took care in our program. We started a program sometime in 2005, 2006. So we've been doing this for almost 10 years now. And for those infants, at least for their short-term developmental outcome, meaning their developmental milestones at the time that they are about between 2 and 3 years of age, that we are actually seeing most of them are able to catch up in their milestones, especially if the primary indication for their mechanical ventilation was due to prematurity alone and not due to any other complications or any other medical conditions that are present at birth.
When you send a child home on ventilator support, tell us how that works. I mean, how are they following? Who's following them, and how do they follow up? Are there physicians on call for them? Is there a nurse that goes out or a respiratory therapist that goes out and helps? How does that process work?
I'm glad that you asked that question because in our program, even prior to tracheostomy, meaning putting the tube for purposes of long-term mechanical ventilation, we meet with the family and as a multidisciplinary team composed of our psychosocial team, our nutritionist, our respiratory therapists, nurses, and everybody else who are involved in the care of that patient. So we meet with the parents and kind of like lay out the plan and the anticipation that once we commit on having that particular patient have a tracheostomy, then these are the expectations that, including what the expectations from the family should be. And then when we get to the point that the baby is already stable clinically, meaning there's not a lot of changes in terms of what the babies need in terms of ventilatory support, then we meet again with the parents, and at that point, we talk with the provider of the durable medical equipment or the DME companies, as well as the provider of private duty nursing, because at the point that they will be going home, we have to make sure that they have the supplier of all the supplies that they will need, as well as they will have the support of the private duty nurses that will be coming to the home and help take care of those babies. In our program also, we have neonatologists who are on call 24/7 to take calls from all of those parents or caregivers at home if there's any question or if there's any problem at any particular point in time. So we are following them very, very closely We do see them very regularly in our home vent clinic, sometimes as often as 1 to 2 weeks after discharge, to make sure that the transition of care from being in the hospital goes smoothly when they go at home. We also have a respiratory therapist provided by, again, the DME companies, who would be checking the ventilators if there's some questions about malfunctions and things like that. So with the coordination of all their care and providing basically the primary care for all of these infants, we were able to, as much as possible, keep them at home and not being readmitted to the hospital. At some point, if they get sick, and we tried our best to troubleshoot whatever they're having problems at home, then we may have to send them to our emergency room and communicate with our emergency room physicians that such patient is coming and needed to be reevaluated, and we keep in touch with them so that we can provide them all the information that they needed to have in order to make that assessment for that particular patient. If that patient needed to be readmitted in the hospital because they're really getting sicker, then they get readmitted to the pediatric intensive care unit. And then we, as our home vent team, also provide co-management while they are in the hospital. And then we also go over again with the parents and the caregivers at the time that they're being discharged, so that, again, the transition from being in the hospital to home will be smooth.
All right. Well, I got to tell you, it's just an amazing, comprehensive program that I know is doing so much for so many kids and families. And Dr. Manimtim, I just want to thank you for the work that you're doing, and thank you for coming on the show. You're listening to Transformational Pediatrics with Children's Mercy Kansas City. For more information, you can go to childrensmercy.org. That's childrensmercy.org. I'm Dr. Michael Smith. Thanks for listening.